Good evening, everybody. On this auspicious evening, we have assembled to celebrate a decade in patient care service of Dr. Qadri's Hematology Center and Clinical Laboratory. At this occasion, Dr. Khuroo's Medical Clinic, Dr. Khuroo's Medical Trust, and I, on my personal behalf, wish Professor Qadri well and pray his center progresses leaps and bounds and continues to serve the society in future. In the next half an hour, I shall attempt to unravel some facts about the most difficult area in our day-to-day practice, and that comes under the broad category of decision-making in clinical medicine. Amongst many items under this vital area, use of laboratory is possibly one of the most important. Over the years, I have held a strong belief that a clinician has to be very vigilant and shrewd in exploiting the huge potential of laboratories and imaging units. Because of this, my extreme indulgence, I have earned many friends and foes from such disciplines. Today I can vouch with pride that Professor Qadri has always been on my right side, and I always enjoyed his association and friendship. Laboratory must be accepted as a huge economic market, and over the years has expanded all over the world, including India. In US, around 5% of the healthcare budget is being spent in laboratory medicine. Laboratory data affect over half of the healthcare decisions, and in tertiary care setting, this could reach even much higher proportions. Astonishingly, around 25% of malpractice suits in US are directly related to laboratory medicine, as against 15% involving the medication errors, stressing the need for surveillance in this area. It has been repeatedly stressed that quality improvement impact in laboratory medicine is out of proportion to the costs involved, making this exercise of quality improvement in this field of medicine highly cost-effective. Let me open this talk by a dictum to the clinicians from the Bible of medicine of what labs can offer. Lab and imaging data can reduce uncertainty about diagnosis and aid in decision making. Thus, these are not ultimate in decision-making process, but a vital aid and should be used as such. Second, diagnostic tests have a wider spectrum than lab tests alone and include procedures like endoscopies, colonoscopies, and bronchoscopies. More than that, this dictum stresses that history and physical is a vital part of diagnostic tests. Also, clinicians often reduce the results of tests as dichotomous outcome, such as positive or negative. However, this is a gross oversimplification and a terrible waste of useful information concealed in the data provided by the labs. Professor Qadri and many others who run diagnostic lab shall be satisfied when I include physicians' activities and abilities in lab medicine technology. Physician has an intense responsibility to do a good consult and to order tests correctly. Poor consult and poor ordering process makes lab data erroneous and suboptimal. After the tests are performed and delivered, physician again is charged with the responsibility of interpreting test data. I must stress that interpretation of any lab test varies from one patient to another and depends upon the patient's demographics, his ethnicity, disease prevalence, his clinical status, and many other factors, which I shall reveal in the next few slides. Asking laboratory to interpret the data is grossly inappropriate and can be dangerous. I shall quickly cover this talk under several titles which will bring out the complexity of the subject in focus. I feel the buck stops at the physician's chamber when I discuss the subject of ordering of lab tests. I feel rather nervous to discuss statistics, a rather hated subject by many of us, while discussing data expression and analysis and understanding of the diagnostic tests. However, I have no other option, even if it makes many of you to take a short nap. Lab errors and evaluation of laboratory shall be one which many physicians would like to listen to, as this is what we all physicians can brag about. Scope of labs has expanded tremendously over years. Many times, case definition includes lab data such as hepatitis B surface antigen positive, HIV positive, etc. Disease diagnosis and use of lab and imaging data have become integral part of clinical medicine. Lab data are essential in disease prognostication, disease response, and clinical course and follow-up. Seroepidemiology has been used as an important tool to document the prevalence of most infectious diseases. Screening of disease is an important preventive tool, and I shall spend some time to discuss its importance. For want of time, I shall stay away from discussing the role of laboratory in jurisprudence and as a powerful research tool. Ordering lab tests correctly and appropriately is our sole responsibility and can't hold Professor Qadri or labs responsible for our mistakes. Studies have shown that improved test ordering makes our and our patients' lives happier, as it makes faster diagnosis, shorter hospital stay, few clinic visits, and improved patient satisfaction. Unfortunately, the same studies have shown that up to 50% of the tests are ordered by the physicians inappropriately, causing a major problem in clinical decision making and an impact on patients' health. I shall take some leads from guidelines from the College of American Pathologists and define how I order tests in my clinical practice. Ordering lab tests is as an isolated item to address patients' clinical problem is inappropriate. For example, ordering hemoglobin estimation for anemia, ordering urea and creatinine for renal disease, or ordering hepatitis B surface antigen for acute hepatitis is inadequate and rarely helps in clinical decision making. Lab tests should either be ordered as algorithm pattern or as test profiles, depending upon the clinical situation you are dealing with. All new patients whom I see in my clinical practice pass through the algorithm protocol for test ordering. I presented here how I would investigate a patient of suspected chronic hepatitis who first time sees me in my clinic. Sequential test ordering for sorting out the clinical problem is what is the basis of the algorithm. It takes more clinical visits, longer time schedule, but is cost effective, and most patients, if counseled properly, accept this protocol well. I use test profile for patients referred to me with defined clinical problems. In this slide, I have shown many clinical problems related to acute and chronic hepatitis and the test profiles I ordered in one block. I know it costs more, but after the profile is done, we are reasonably ready to be for an effective treatment protocol. Many reputed labs have started extended test profile on discounted rates and widely publicize it to catch the public eye. I've shown one such discounted extended profile here. Such labs have come up with the slogan that this protocol has a preventive role. I do not approve of this as a strategy, as it has not passed through the basic structure of decision making to evaluate for screening and prevention of any disease in general population. I shall address this issue later in this lecture. Let me attempt to focus on the complex issue of data expression and analysis in laboratory medicine. For any value reported by the lab, a reference range for the population for that value is established. This is done by measurement of such values from a small number of subjects thought to represent the population. These values are plotted on a histogram and pattern of distribution is defined. These could be symmetric, as in this plot, what is called as a normal distribution, or could be skewed in distribution. Based on the type of distribution of these values in the representative population, a reference value for these indices is established either as a mean for normal distribution or mode, median, or geometric mean along with the range if the data are skewed. We must also understand how values of normal and disease group behave on a scattergram. It is unusual for values to be distinctly separated from each other from a normal to a diseased, and many of them overlap. Most often these values overlap, and some values of the disease group will be similar to that seen in the non-disease group. I hope you take note of these slides, and let me move ahead of how values in the labs are expressed and analyzed. Thus, results on a sample can be reported in a number of ways, and it may confuse the young physician. Some reports are reported as dichotomous, as positive or negative. Here the test results of a normal and diseased population do not overlap. Other results are reported as categorical, as mild, moderate, and severe. Here increasing values are proportionate to the severity of the disease process. However, more often than not, most lab tests are of continuous type and depending upon their distribution in normal population are reported as mean, mode, median, or geometric mean. Mean values are reported in normally distributed values. Median and geometric means is calculated to reduce the impact of the extreme outliner observations. A range for the value is calculated from plus minus 2 standard deviations around the average and includes around 95.4% of the normal values. This much about the reporting of lab values in clinical medicine and your endurance to bear with me. How does a clinician evaluate these values? Sensitivity of the test value is defined as the probability of those with disease who have a positive test. Against this, specificity of a test is defined as probability of those with no disease who have a negative test. These values can be calculated from this table by simple calculations as shown. Next, let us define the predictive value of a positive and predictive value of a negative test. The definitions are reversed, keeping test as the focus. Predictive value of a positive test is proportion of individuals with positive test who actually have disease. Predictive value of negative test is defined as proportion of individuals with negative disease who have no disease. Calculations are done. To sort it out further, let's look at the value of the test in your hand reported by the lab. A reported positive test may belong to a patient with disease, called the true positive, or may belong to a patient with no disease, called the false positive. In contrast, a reported negative test may belong to a patient with no disease, called the true negative, or belong to a patient with disease, called false negative. These rates can be calculated as shown in this slide. Statisticians have gone further to plot the relationship between the true positive test, what's called the sensitivity of the test, which is a desirable test evaluation, against false positive test, which is 1 minus specificity, and undesirable evaluation of the test, and drawn receiver operator curves as shown in this figure. I present the famous reported receiver operator curves of 3 diagnostic tests in the evaluation of coronary artery disease. It's clear from these operator curves in each diagnostic test that there's a trade-off between the improved sensitivity and improved test specificity. If we want a better sensitivity, we drag on the specificity and vice versa. Clinicians have to understand this complex relationship of a diagnostic test and read these as such rather than as a positive and a negative test. Clinicians would have been satisfied if it stopped here. However, it doesn't. The matter becomes more complex by the concept of what we call as pre-test probability of the disease in general population and the concept of Bayes' theorem. The reason I present this concept here is my intense belief that a clinician can never read a test result optimally if he doesn't understand the concept presented in these 2 slides. The fact remains that a test result needs to be applied to a population and its overall value is directly related to the prevalence of the disease in that population. Let us suppose a diagnostic test has a particular sensitivity and a specificity and a calculated determined likely ratio of the disease. The actual overall accuracy, what you call as post-test probability, is determined by the pre-test probability, that is the prevalence of disease in general population, and the likelihood ratio. The same test applied to a population with low prevalence has a lower overall accuracy, while the same test applied to a population with high frequency has a better post-test probability. Post-test probability can be calculated on a likelihood ratio and the pre-test probability as shown in this slide. This slide shows the famous nanogram nomogram version of the Bayes theorem. The pretest probability of the disease in general population is shown in the left vertical bar. The likelihood ratio determined by sensitivity and specificity of the test is released by the lab is shown in the middle. We can directly calculate the post-test probability by joining points on pretest probability and likelihood ratio and extend it to hit the post-test probability. Screening and prevention of disease through lab tests and diagnostic tool is one of the most important services labs can offer to mankind. I present to this august audience as how preventive diagnostic tools are evaluated in general population. Population with disease is randomly divided into two groups, one with the introduction of the diagnostic test and second keeping as a control. Endpoints for preventive strategies include the number of individuals needed to alter outcome in one patient, absolute and relative impact of screening on the disease outcome, cost of one life saved, and increase in the average life expectancy for the population. U.S. Preventive Task Force has made a number of recommendations which have passed the preventive strategy. Few of these strategies, along with the target population and the frequency, is shown and well known to many clinicians all over the world. The impact of these strategies in increasing life expectancy for a defined population is shown. The role of PSA, or prostate-specific antigen, estimation in prevention of prostate cancer is controversial as of today, and this issue has received considerable debate in the recent past. Most comprehensive preventive strategies include lifetime modification, including stopping smoking and regular exercises. Mammography and colon cancer screening strategies have shown their mettle in the fight of these two dreaded cancers in the West. As I mentioned earlier, lab-driven discounted extended health profiles is a stunt used by the reputed labs just for commercial purposes and cannot be included in the preventive health strategies as they lack these or such scientific data. Let me turn to the subject of lab errors, which many of you might like to listen to. The dictum is that lab tests are essential in disease evaluation, follow-up, and treatment. However, the reproducibility of lab test results is a major concern among patients and clinicians both. I have seen patients doing the same lab test at multiple labs and getting flabbergasted by the variation seen in the same sample tested at different labs. What causes lab errors and how to address these issues is a subject of great importance to many of us. There are multiple steps in the lab testing, and error can occur at any step. It's important to note that most of the lab test error occur outside actual testing of the sample, and these include patient identification, labeling, sampling, and transportation. Thus, when we are discussing the quality assessment efforts, these must be broadened to encompass errors in pre-analytical and post-analytical steps in lab testing. Clinicians have to be very shrewd in reading every lab test results and read it carefully, keeping the patients in mind. Lab test results can be suspected to be erroneous under several situations, including exceptionally high or low values, values which are significantly different from earlier reported results, results which do not correlate with the patient's clinical status, and values reported on poorly collected and maintained samples. There is a recommended action plan when lab test error is suspected. First, the lab should be informed in writing and errors in transcription checked, and if so, corrected. Next, the original sample, if available, should be rechecked and a fresh sample taken and tested. If the test value is validated, ball lies in the clinician's court to explain these abnormal test results. However, if the test error is confirmed, an updated, corrected report by the laboratory should be released. How does a clinician at the receiving end evaluate which lab to choose amongst the mushrooming of the labs available? Look at multiple parameters which a lab may or may not satisfy and then take a decision. First is the issue of certification and accreditation. Find what is the level of quality control and quality assurance lab is implementing. Is the lab manually run or has introduced automation? And to what level the automation has expanded? Does the lab use computerized lab automation informatics system? Apart from these high-tech tools, which you might have to consider, you as a clinician have to be comfortable with the lab's overall control, quality of manpower employed by the labs, rapport with the labs, how much time labs take to report the test, does labs inform patients and physicians about the alarm results to safeguard patients' interest, and so on. I must mention, with the introduction of excellent national reference labs, there has been development of satellite centers all over our country and tremendous mushrooming of the collection centers. And these have introduced some difficult problems in collections, sampling methods, and transportation, and also in the reporting. I believe these have not been studied well and need a thorough, dedicated study and analysis so that the physicians can interpret those results from those studies. In this CMV, I'm eagerly awaiting a lecture on lab accreditation and quality control and quality assurance by one of the legends in lab medicine. And I would not venture to step in this area except to tell the audience that certification and accreditation is a third-party certification for lab competence and infuses confidence in lab users. Quality control and quality assurance, as you're going to listen to the expert, is important lab activities which determine accuracy of the test results and a mechanism to critically analyze and sort out all steps of lab testing. Laboratory automation by automatic analyzers has the potential to increase productivity, reduce exposure hazard, decrease lab cost, and enhance lab turnaround. Automatic equipment makes results far more accurate than manually tested results for several reasons which have been well documented in literature. Several lab tests support automation, which includes coagulation, serum chemistry, hematology, urine analysis, and immunology, and few more. Automatic analyzers are wonderful tools and machines, and if used correctly, can identify sample and patient, measure and add reagents, mix samples and reagents, incubate and calibrate the assay, and measure and run the test reaction, and record, analyze, and store sample. What else you need to do? Lab staff can be highly productive with these wonderful machines. Now automation has expanded to pre-analytical lab tests, including barcoding, reading, sorting samples, transport, centrifugation, decapping, recapping tubes, allocating specimens, quality detection, storage, and these pre-analytical modules can be coupled with analyzers to improve capability of processing and sampling and reduce lab errors in these processes. Thus today, optimized computerized lab system can involve automation in all steps in lab testing, maybe pre-analytical, analytical, and post-analytical process, as shown in this slide. Clinicians must make inquiries as to what level of automation lab is using and evaluate labs on these scores. Lastly, computerized laboratory informatics system, if introduced in the lab, can reduce errors through a number of ways, including identified mismatched reports, specimen mix-up, calculation errors, transcription errors, and errors and omission. Apart from this, this informatics system gives a number of other benefits to the lab. And for us, we can get reports on a simple phone call in a minute and can download these reports sitting anywhere in the globe with an available laptop and an internet connection. Ladies and gentlemen, I've taken you through a difficult journey of how a clinician can use lab intelligently, and I believe this is one of the most important activities in clinical decision making in our day-to-day practice. I would thank you for bearing with me and have a good day. Thank you.